Hi, everybody. Welcome to our special Perimenopause Awareness Month session on breaking the stigma for millennials. I'm LaurenA.Tetenbaum. I am a licensed clinical social worker based in New York and the author of Millennial Menopause, preparing for perimenopause, menopause, and life's next period. And it is my pleasure to be here today with my friend and colleague, Dr. Adrienne Mandelberger. Want to go ahead and introduce yourself?
Sure. I am Adrienne Mandelberger. I am a gynecologist by trade, and I am the owner of Balance Medical, which is a specialized private gynecology boutique where I focus predominantly on menopause and perimenopause, but also full spectrum gynecology. And I'm also the founder of All Things Menopause, which is a mostly educational company devoted to all things menopause, basically education surrounding menopause, perimenopause, and just trying to get the word out there.
And we are both millennials, we should say.
Oh, yeah.
Technically, millennials were born between 1981 and 1996, but we are always happy to chat with anyone of any age. Dr. Mandelberger, do you remember learning about menopause when you were growing up? What did you hear about it? What did you know about it?
It's hard to undo the more recent knowledge or I remember, I knew it was the cessation of periods. I think I knew about hot flashes. And that's really it.
Yeah.
That's it.
I knew.
I equated it with old, right? It's like, old women, menopause, which clearly is not the case, given we're millennials.
Well, and so clarify for our audience, at what age do women typically go through menopause?
Well, the average age is 51, but the range of full menopause, not perimenopause, full menopause is basically plus minus 10 years. So anywhere from 41 to 61. And then perimenopause can happen up to 10 years before that. Mm-hmm. So do the math. That could be 31.
Right. 31 is when the symptoms can begin. And that's for quote unquote natural or spontaneous menopause. We're not even talking about early or induced or premature menopause. And I, too, knew very little growing up about menopause. I knew that it was the end of one's periods and one's fertility. I associated it with silver-haired ladies, not that there's anything wrong with that. With osteoporosis, I knew that was somehow connected and low bone density, but I had no idea how it was all connected. I certainly did not know that symptoms can start in one's 30s. And that's why I set out to learn more. And that's how you and I got connected, because I thought, what is going on here? What is happening to our bodies and our mental health and our moods as we approach, quote unquote, midlife, middle age? And what can we do to set ourselves up for success? So I'm so happy that we're here together. We have some questions from the Perry community that let's answer together. And I'm going to have you answer this first one, which is something that you answered for me a year ago. And I was researching for my book, which is, are there any tests to diagnose perimenopause? How do I know I'm in it?
It's a great question. And it's one that is not a good answer, unfortunately. So there are no tests. There's no blood tests to diagnose perimenopause. The technical definition of perimenopause is based on a set of criteria that was established by a group of experts quite a while ago. At this point, it's called the Straw 10 criteria. And basically, according to their definition, the definition of perimenopause is 2 consecutive menstrual cycles whereby the timing of the cycle varies by at least, I believe, 1 week. So twice in a row, you're off by a week or 10 days. And so what if you don't get a period? What if you have an IUD? What if you're having all of the symptoms, that can go along with perimenopause, but you're still getting a regular period? Does that mean you're not in perimenopause? I have some issue with this diagnosis, or criteria rather. Now, it's important to have criteria when we're studying, right? When we're doing the research, we need strict definitions to know who to include and exclude in certain studies. However, when it comes to clinical work, real life work, if you're seeing a patient in front of you who's having all of the symptoms and they're still getting a regular period, you're going to say, sorry, not in perimenopause, can't help you. That's not realistic. And unfortunately, that's what's happening all over the place. So I think we need either another terminology, a second definition, or to alter that slightly so that we can include those patients, because realistically, I'm treating that patient that still gets the regular period because they're very highly symptomatic.
So that was so helpful. I would say, as a clinician that is not a medical provider, something that I pride myself on is treating the symptoms and not the diagnosis. And I think our culture gets caught up on labels, and we do that for insurance purposes, et cetera. But I think that's what you're saying, that yes, perimenopause, perhaps by the straw definition, perhaps not. But if you're seeing a woman in front of you who's complaining of mood swings and irritability and brain fog and midsection weight gain, those are symptoms that you can appropriately assess and diagnose as perimenopause and in need of treatment. So how do you treat a woman in perimenopause? And of course, no woman is the same, but what are some resources or tools in our toolbox?
So I tell my patients, it can be tricky, honestly. We don't have enough resources and we don't have enough tools for perimenopause. Menopause, truthfully, is much easier to treat. And the reason for that is the menstrual cycle. So in perimenopause, we are still cycling. It could be regular, it could be irregular, but those cycles vary wildly. So from cycle to cycle, you could have, let me back up a little bit. So basically what happens is the hormonal signals, as the availability of viable follicles in the ovary begins to decline towards the end of the reproductive stage, that feeds back to our brain, to our hypothalamus, and tells the hypothalamus, hey, I'm running out of eggs here. And because evolutionarily our bodies want to reproduce, the brain, the hypothalamus, responds by sending out more stronger signals to ovulate. So the brain says, oh, we're running out of time. We're running out of eggs. Let's get those puppies out before it's too late. So those signals strengthen, talks to our ovaries, which then they're receiving these stronger signals, and there still are viable follicles there. So sometimes you're throwing out 2 follicles or you're throwing out 1, but those hormone surges are stronger because the signals they've received are stronger. So essentially what happens is you can have some cycles where the hormones are surging, and some cycles where, okay, maybe that signal, maybe it is really running out and that signal is not making it there, or it's not being received and able to ovulate to its full capacity. And then you're having these low hormone cycles. So there can be cycles. This is what gets confusing to patients. There are some cycles where the hormones are much higher than we're used to. And that itself can lead to many symptoms. So for example, one symptom I commonly see that always gets tricky to really, we have to hone in on what time of the cycle is migraines, for example. Patients that suffer from migraines are often hormonally, either fully hormonally mediated or like kind of be influenced by hormones. And that could be both directions. So some women get migraines from the hormones themselves, like too much estrogen can give you a migraine. And some women get migraines from the withdrawal of such. So that gets really tricky because you're trying to tease out, well, is it are we having a surge, or are we having a low, or are we having a decline? And so there's really no one right answer as to how to treat perimenopause. But let's talk about some basic principles. I have like 4 sort of ways that I think about approaching this problem, and it's based on sort of what happens, with these cycles, how they're varying high to low. The 4 main approaches that I use are basically breaking the cycle, so shutting down the cycle altogether, raising the baseline, so maybe patients that are getting later in the process and most of their symptoms are from low estrogen, we can just sort of bring that estrogen back up. Or even if the symptoms are from the rapid decline in estrogen from going from here to here, if we raise that baseline, it softens that blow a bit. And then another technique I use, I call turn down the volume. And this is really, really important. This is where we try to quiet the negative symptoms and signals in our bodies that come from these changes. I explain to my patients that we kind of lose a bit of our resilience in this time frame. There's so much going on that we have a less leeway to treat our bodies in certain ways and be able to recover like we used to. And so essentially doing everything you can to lower inflammation in your body, make sure you're getting everything you need. So all of the lifestyle aspects, we want to lower that inflammation. So exercising regularly, sleeping well, eating clean, eating well, making sure you have adequate nutrition. And so these things and stress reduction is humongous, of course, mental health. So all of these things have a huge, huge impact on the signals, which I call it like the nervous system overload. So, if you are inflamed, if your body is not doing well, you're going to experience pain at a greater rate, right? Imagine when you're really stressed out and you haven't slept well and you haven't eaten well.
Not good.
Everything hurts.
Yeah.
Everything hurts, right? And so basically quieting the signals, the negative signals, whatever they may be, because you get neuroinflammation, which is like, how it affects your mood, and you get joint inflammation and, musculoskeletal symptoms. So just quieting these signals by doing everything you can to treat your body well. That is lowering the volume. And those are like the 3 big ones. And then the 4th is more targeted towards bleeding issues, which we can get at if you want to. But let's talk about going back, because I think this is like probably the big important thing that people want to know. So that was turning down the volume. Let's get back to breaking the cycle. So breaking the cycle, this is truly our tried and true classic perimenopause treatment that often is the only treatment offered now to women, at least by providers who are not especially trained in menopause and perimenopause. And that is something like the birth control pill or other combined hormonal contraceptives. These contraceptives work by essentially stopping ovulation, right? Preventing ovulation. And what that does is that inhibits this cycle up and down, up and down, up and down with the hormones. So you have this sort of low level baseline. Now the contraceptive is giving back, or, introducing slightly different but very similar hormones that will at least give you some of those hormones, hopefully, to treat some of those symptoms. Doesn't always work perfectly for everyone. For example, not great with hot flashes, but the pill will shut down the cycle and give you back hormones at the same time to avoid the crashes and peaks and troughs that can be really problematic. And that can be a really life-saving option for many, many women. A lot of people sort of poo-poo the pill. Oh, the pill is bad. There's a lot of
stigma.
There's stigma, and there's side effects. Truthfully, there can be side effects, and some women just cannot tolerate it. But I think keeping an open mind when you approach this issue is really, really important, because that might be the thing that is going to make you feel the best, and there is nothing wrong with that. And then the last one, raising the baseline, right? And that's our sort of more traditional, not perimenopause treatment, but menopausal hormone therapy, which nowadays in my practice tends to be probably our most prescribed for perimenopause. Even though I tell patients, you have to remember, this is not going to cure the symptoms. This is going to soften, hopefully, some of the symptoms, but we really have to be careful in how we describe this, and not describe it as a panacea. The panacea, which still it's not, of course, but it's really in menopause. So when the periods are fully ended, right? When the periods are done, our hormones are tanked, right? We have almost no hormones after menopause. And menopausal hormone therapy is going to give those back, and is going to alleviate the majority of the symptoms related to withdrawal of hormones. But in perimenopause, we're still cycling. And the hormones that we give in menopausal hormone therapy are not so strong or robust. They're less than our natural cycle. So we're sort of softening that blow a little bit, but you're still going to be cycling, and you're still going to have some of those cycles where it's really high. So a lot of times patients, this is like a classic way that they come back to me. So we have the conversation, we have our initial consult. They decide to choose menopausal hormone therapy for perimenopause symptoms. And then first month, they're like, I think it's really helping. I feel a lot better. It's doing great. And then maybe 2, 3, 4, or 5 months later, they come back and they're like, my symptoms came back. And I'm like, you might not recall because you've been feeling so well, but this is a very real possibility, because you're going to have some of those cycle surges. The other big consideration is that if you are one of those patients that the majority of your symptoms are coming from the surges rather than the declines, menopausal hormone therapy can make that worse.
So it's very important to work with a provider who is aware of all of the nuances.
Yes, and it's very nuanced.
Yeah. I'm certainly happy to collaborate and listen and believe you. I think a lot of the women that we see are told you're too young for perimenopause, or there isn't much we can do about it.
Right.
And it was so fascinating for me to learn that the stigma around hormone therapy persists in the medical community. Now, you, I know, sought additional training. You've become an expert in this field. You're a member of the Menopause Society, certified practitioner. But unfortunately, so few providers currently are. And this, we don't need to get into the WHI study from 2002 in detail, but basically it created this impression that hormone therapy was dangerous and not an option. And I think we are still very much seeing the legacy of that stigma today. Do you find yourself explaining to patients often that hormone therapy is a tool in our toolbox and not something to automatically worry or be afraid of?
So I will say, this is just by the nature of like how I, present my practice now versus before. I would say before, when I was employed working for a large health system, I was doing that all day long, right? All of my annuals, all of my I'm feeling menopause symptoms, what can I do, was focused on breaking that stigma of the damage that the that was done by the misinterpretation. I don't like to say how terrible the WHI was, because it really wasn't a terrible study. It was just the way the information was presented and misconstrued. And so, yes, previously that was the majority of my day, trying to kind of backpedal on that. And actually it was really gratifying, because it was, for all these patients, it was eye-opening. Now in my current practice, because I'm a menopause, perimenopause specialist, provider, listed on Dr. Mary Claire Haver's website, where so many patients find me, many of them are already pretty educated, and have come to me on their specific stories, but there's less of the myth dispelling, because I think most patients, by the time they've gotten to me, they found me because they already did their own self-exploration, which is nice. And there's definitely, this is definitely a thing. This is happening. The information's getting out there, which is really, really exciting. And I would say, from the provider, the physician standpoint, I'll say kind of what's happening behind the scenes, because I'm in various physician groups online, of, not all of which are devoted to menopause by any means. So I think two things are happening here. I think from the physician standpoint, one thing is really, really positive, and that's, okay, I really need to get educated, right? Like, everybody's talking about it. All my patients are asking me. I better figure this out.
And now some states are going to mandate it, which is great for training for physicians. Yeah.
Wonderful, wonderful. And so that's one half of it. And the other half of it, and, let's not demonize them, because remember, they're extremely crazy schedules, and they have their 5 minutes and 12 patients in the waiting room, and the stress they're under. But what ends up happening is then now a patient comes to them as if they would come to me, asking about perimenopause and menopause, and could this be related? And that is I take an hour at least, and often I don't even finish. I have to bring them back to talk more, because that is a big, big conversation to be had. And some of the physicians end up oh, again, here we go again, another patient asked me about menopause, which is great. Keep doing it, because it's putting pressure on the system. But that's some of the feedback that is coming from the other end, is everybody's talking about it, and it's almost meeting resistance in that way. Oh boy, another person's asking about menopause. Everybody thinks they're in menopause, so there's a little of both happening, which is both fortunate and unfortunate on that end. But I still think it's really important to keep putting the pressure on the system as a whole.
And I think it's just important to talk about it, to normalize these issues. I feel like a lot of 100%. The women that I see in my practice as a therapist are the women who don't know that this is something that could be affecting them at this phase of life. The lack of resilience is absolutely something that I see, the sudden mood swings, irritability. And we know that up to 70% of women experience mood shifts during perimenopause. It doesn't necessarily mean that they're in a full-blown major depressive disorder. But like we said earlier, whatever they're feeling that is not feeling good, they deserve support for and treatment for and resources for. And it's been so cool for me to be able to refer them to providers like you. And so, when they get to you, they already have a bit of that psychoeducation. They know that perimenopause is a thing that can happen in their 30s or 40s. It can certainly happen during the postpartum period as women are having babies later and later, which is something that we didn't really talk about before. So I think the more we talk about it, the better off we all are, because knowledge is power. And when we normalize these issues, we feel 100%. Much less isolated.
100%.
I do still see a lot of trends around getting hormones tested, or providers saying things like, well, your labs are normal. So we got a question from the Perry community of what is the value of having your hormones tested? And I believe that the menopause societies rule of thumb here is it's not really necessary in perimenopause because it's fluctuating. But so whatever your levels are on Wednesday morning might be totally different by Thursday afternoon. So it's sort of valueless. But I know that providers are saying, look, if the woman patient wants her hormones tested, she should be able to get them tested, right? Her body, her choice.
Right.
What are your thoughts?
I think my thoughts are both of that. If you explain the both sides of a story to a patient, they get it. Patients understand. Like, you take the time. Yeah, exactly. I'm not so paternalistic. I really, my patients, when I tell them why, the pros and cons of something, they understand and they can make their decision. The important thing when approaching any test is, what might the results mean and what can I do about them?
Right.
Right. In perimenopause, it's true. Like, it's not a diagnosis from labs, and you can't diagnose it on one lab. Now, there are exceptions. There are many times that I will get hormone levels on a patient to try to, it's part of the clinical picture. Let's put it that way. It is one small part of the picture. So when somebody's symptoms are confusing or not so classic for perimenopause, or, have many of these symptoms overlap largely with other pathologies, other diagnoses that could be really important, of course, medical diagnoses that need to be explored. And so when trying to tease that out, sometimes it can be very helpful. And what about the patient that doesn't get a period for whatever reason, and we have no clue? We don't have much else to go by. It's important to understand how to interpret the results. So let's say I have a patient who has had a hysterectomy. They don't get a period anymore, but they do have their ovaries and they do still ovulate and have their cycles. They're not bleeding, but they have hormonal cycles and they could have all of the same symptoms. If I'm trying to tease out whether or not they might be in perimenopause, I'm probably going to get, if I don't know clearly from their symptoms, I'm probably going to get labs on that patient. Now, when those labs come back and they look like a normal reproductive aged woman who's still cycling, it doesn't tell me so much. But if those labs come back, so basically if it comes back like that, they could still very well be in perimenopause. It does not rule out menopause or perimenopause. Well, no, it rules out menopause, but it doesn't rule out perimenopause. But if those labs came back and look like a completely menopausal woman, that's not normal for a reproductive age cycling woman. And so that is information that is helpful. So it's not a yes and no black and white answer. It's part of the full picture. Now, in that first patient whose labs came back like a reproductive age, or younger reproductive age woman, I might repeat the labs at a later date or at a different sort of time in what seems like the cycle. So they can be helpful. They should not be a universal screening test by any means. And I know there's a lot of push out there, like everybody should vouch for themselves and demand a hormone test, but I don't think that that's the right approach. I think the right approach is a full discussion of the risks and benefits and how helpful this test could be in a specific patient. Because in some cases, again, if you're trying to self-advocate with maybe not a specialist, not a menopause specialist, those tests can often be dismissive. So if it comes back normal, your doctor might tell you, if they don't have a full understanding, they might say, well, you're not in perimenopause. I've had friends who were like, I have to come to you. I have all these symptoms. And I'm like, yeah, come. And and I'm like, a few months go by and I'm like, hey, I thought you were going to come, you want to come see me. And she's like, and they're like, oh, well, it's fine. I had my hormones tested. I'm not in menopause. And I'm like, well, like, I can't really comment if I'm not their doctor, but I try to, I'm like, I don't know, could be, but okay, when you're ready, come.
Right. It goes back to talking and listening, right? Yes. And I too don't want to demonize the providers who are not necessarily doing the best job listening. But to the patients out there, I will say, if you're feeling unheard or dismissed, yes, there are other options and you deserve better, because it isn't just about labs, which can look normal on any given day. It's about how you're feeling. I do have a specific medical question here from the Perry community, which is, can ovarian cyst removal lead to early menopause, which is technically before the age of 45?
It's a great question. And actually my first specialty was and is as a minimally invasive surgeon. Mm-hmm. And so as a fellowship trained minimally invasive surgeon, I deal with things like cystectomies all the time, and endometriosis. So this has been studied quite a bit. And usually the studies focus on testing levels, not hormone levels, a different type of hormone test that I'll explain in a minute, as opposed to looking at long-term actual menopause outcomes, which is obviously a harder study to design because you have to follow these often young patients out many, many years. And so most of the studies look at a test called AMH, which is another tool in our toolbox, by the way. AMH, anti-Mullerian hormone, traditionally has been utilized as part of a infertility workup. An AMH level is correlated with the likelihood of success for an IVF cycle or an egg basically an egg retrieval. So that could be oocyte freezing as well. So the lower the level, hypothetically, the lower the ovarian reserve. Another test that's really important not to misinterpret, because it doesn't tell you that you're in menopause, but there is a correlation of that level steadily declining up until menopause. So in endometriosis studies, so if somebody has had an endometrioma, which is an endometriosis cyst on the ovary, removed, that does lower your AMH levels after the surgery. That persists. So it's very common to have that basically lose some follicles as part of an endometrioma removal. At the same respect, on the flip side of that, having that removed also improves your chances of pregnancy. So if that's what we're going for, it's short-term gains, probably, if you're trying to get pregnant, most likely outweigh the long-term detriment. Now, does this induce early menopause? By definition, that completely depends on the extent of the surgery, when you are going to naturally go into menopause, which who can say that, right? Nobody can predict the future. But essentially you can say that it's probably going to knock off maybe a few months to 6 months, something like that, in your menopause time. The same, believe it or not, can be said about hysterectomy. This is a relatively newer finding. We used to, when I was in training, we used to counsel it's not going to make a difference on your ovary. We're leaving your ovaries, in our hopefully most hysterectomies these days, when a younger woman is leaving the ovaries, if it's not for cancer or otherwise, whatever. If the ovaries are staying, then it's not going to change menopause at all. When actually we found out that it actually probably does expedite menopause by about 6 months. It's not a huge difference in the scheme of life, but it
Something women should know, should be given the option to give actual informed consent.
Exactly. Exactly.
There was an article last year about how many women are not clear on what organs they're getting removed because there are so many mislabels. And I know you're talking about hysterectomy, the removal of the uterus, not the ovaries, but a lot of women get confused about that.
It's hard. I have to say, as somebody who's a surgeon who does hysterectomies and gives very thorough explanations, that message doesn't always get through because that's not what they're thinking about at the time, right? They're not worried about that at the time of the surgery. They're worried about the surgery itself, getting through it, or whatever it is. I don't have the exact explanation, but my own patients, I'm embarrassed to say, like, later, a couple of years later, was like, did I have my cervix removed? I'm like, oh man, so it's.
But they know they can come to you and get clarification.
Yes. Make sure you get your operative record, keep that with you. That's the easiest way to always know.
Yeah. And I think that speaks to the importance of collaborative care and having a mental health professional or some sort of patient advocate on your team as you embark on this journey towards your healthcare that can have profound repercussions, because it's not just a surgeon that you need, right? You really need to set yourself up for success all around. In general, do you feel like your friends and people in your personal life who are millennials are talking about these issues more and more? I do feel like, and maybe it's our algorithms, but, certainly the New York Times seems to be talking about it, pop culture, Oprah, etc. I still personally think that it's positioned as an older woman's issue. But I think hopefully through our work, we are educating our peers, our generation, on what to pay attention to now. What do you think?
I 100% agree. So I think that's probably I don't want to speak for you, but both of our biggest missions it's true. So of course it's way more out there in the media, social media and actual media, talking about menopause, perimenopause, yada, yada. But when it comes to peers, friends and other women our age, many of them are like, oh yeah, everyone's talking about that, but that doesn't apply to me. Right. It's like,
I'll deal with it later when I have
to. Right. I think it's a little bit of denial. We're in that age frame where like, we still feel very young and we don't want to think of ourselves as aging. Obviously everyone's aging at all times.
Right. And it's a privilege. It's better than the alternative.
Agreed. And I think what we really we want to thrive, right? We want to thrive at every age, and an understanding of what's to come and what can I do about it now to optimize my outcomes, which is one of my biggest push and passions, is so, so important. And so yes, I think people are sort of like hearing it, but obviously there's both, right? There's women that are embracing it full force, and there are many that are still sort of brushing it under the rug for a later date. And I think now's the time. Many women our age are still in the throes of motherhood, not everyone, but or career building, or both. And it's busy, and like, who has time for ourselves? But what I will tell you, as somebody who has seen hundreds of patients in menopause and perimenopause, that, we're all kind of always like postponing for the future, right? Okay, well, when my kids, when they go to college, I'll deal with it later. When they go to college and I'm established in my career, that's when I'll be good and I'll have time to devote to my health. That is when you're going to be suffering the most. I hate to say it, but that is that tends to be, I've seen it so time and time again, like they've finally gotten to that point that they've been waiting for, and then they feel like crap because they didn't address it soon enough, or that's when it's just coming about and they don't know, and they're like, oh my God. But being prepared for that and doing what we can now, which I'm just going to throw it out there, easy thing to do, start strength training, build that muscle now.
Yeah. That's the first thing I started implementing in my own life when I was researching perimenopause. I said, okay, better get a trainer, better get some girlfriends. Because, and we know that social connection is also so good for our mental health, our cognitive functioning. So now I work out with friends and a trainer doing strength training. And I'm so glad that I've set myself up that way. There was a specific question from the Perry community. What can I do to prepare? So you're saying the strength training. Of course, I'll say read my book, which covers everything and has more of Dr. Mandelberger's advice. I would also add create a support team. It may or may not include specifics, meaning this is my gyno who's going to help me and their phone number. It certainly could, but also think about what you will need, which is likely going to include mental health support. I know that for many of the women I counsel who are postpartum or pregnant, when they learn that up to 1 in 5 women experience a perinatal mood and anxiety disorder, they don't get more nervous about that. They actually feel more prepared and less alone, and then say, okay, I'm not going to be imagining it. I know how to find resources. I have a therapist in place. And it's like assembling your team of care. And I think it's really important to just know yourself as you enter into this phase of life, know what is a little bit different, and then how you can access resources for that.
100%. I totally agree. And then the biggest piece is also just education now.
Yeah.
So between your book, I have a course that is geared towards like the educated but not physician woman. Just learn everything you can, and also start understanding your own specific risks.
Exactly.
Right. So knowing what you personally, we're all at risk for everything hypothetically, but does your mother have osteoporosis? Right. So many patients don't even know that. They never ask, what is what's your cancer history? What's your heart disease family history? What are your genetics like that are going to, not be deterministic, but increase the risk, and that you can work on other modifiable factors that can decrease that risk, and start actively working towards those now.
Exactly. Knowledge is power. And similarly, if you've had a mental health issue in the past, especially around a reproductive event like puberty or pregnancy, you are at higher risk of experiencing depression during perimenopause. But that doesn't mean that you're doomed. That's just knowledge. It's a data point. And then you can, again, collect your team of providers who can help you through it. And also other social supports. It's so important to have people in your life that you can talk to about it. Again, it goes back to talking about it, to breaking the stigma. And I do want to get into a question we got about breaking the stigma in the workplace. The question that we got, which is one that I love, is how can the millennial generation make menopause-specific benefits in the workplace the norm? So I love this question for many reasons, including the fact that I used to be a lawyer at a big law firm. So I'm an advocate at heart, and I also have experience in changing workplace policies when it comes to reproductive health. And the listeners, I don't think, will be surprised to hear that my first response is talk about it. We need to normalize this natural phase of life that half the population goes through. I would encourage everybody to go to the Menopause Society's Menopause at Work platform. It's free. They give so many amazing free resources, including discussion points to have with one's managers, HR policies that can be implemented. So many great resources that are right there. And what we know from the data out there is that the number one reason why menopause benefits are not currently offered is because employees don't ask for them. And I know that that feels burdensome because, like Adrienne said, we're already dealing with a lot at this point in life. And to tell ourselves, oh, now we have to go change policy, that sounds really exhausting. I totally get it. But also, like what she was saying, let's ask now before it's an urgent need to get menopause benefits, which can range from control over the thermostat, paid leave time off to engage in appointments or self-care activities, educational trainings for everyone in the office, including men, including managers, also partnerships with doctors like Dr. Mandelberger or other clinical practices that provide menopause-specific care, because in the US, we're so reliant on our employers for healthcare coverage and accessibility. And so we really want to make sure that we're getting the care that is actually helpful with providers who know what they're talking about. And that can include a broad spectrum of gynecologists and nutritionists, et cetera. But it's been called the new frontier of corporate benefits, the menopause space. And I believe that it is. I believe employers who don't get involved are on the wrong side of history. So it's never too early or too late to start talking about it at work. Anything else you want to add to that?
I completely agree. And if you have any pull in, or if you work in HR, or if you have, a pull in your own company, suggest this to the powers that be to bring in at minimum education. Yes. I had the privilege of giving my course to a school district as one of their HR benefits. And I was so honored to be able to do that. And yeah, we just need to keep pushing the word out there. And I think the benefits will follow once the corporate world also gets educated.
Absolutely. That's very cool. I'm happy to hear it. I am also going to be speaking at a couple of educational lunch and learns for companies in October, which is Menopause Awareness Month. But this is the beginning. There's a lot of work to be done. It starts with talking about these issues among our friends, with our partners, with our kids, right? Normalize the reproductive health cycle of a woman, normalize periods. I really believe that we just need to talk about this to break the stigma. So I have a fun question for you before I ask where people can find you. What is your favorite memory or piece of millennial pop culture? What was your favorite song growing up or TV show?
Oh, there's so much. I mean,
it's the best era.
I was a huge Dawson's Creek fan.
Nice.
What else?
They're having a reunion.
They are?
Yes, but it's sold out already. And it's in New York. So Dr. Mandelberger and I are both in the suburbs right outside of New York City, and we both offer telehealth. But next time the Dawson's cast and crew gets together, please let us know, because we missed out on the very quick ticket sales for their upcoming reunion.
What's your favorite?
I also loved everything on the WB, and I was a huge teeny bopper boy band girly. And I will tell everyone that I met the Backstreet Boys a couple weeks ago. So that was like a life highlight. So that was really fun.
The Delia's catalog. I'm going to throw that one out there.
Amazing. So classic, like getting it in the mail, circling which ones you wanted. That was the Y2K, we can say what we want about it, but it was a fun pop culture time. And I think it was nice not to have social media in many ways. But speaking of social media, where can people find you?
My Instagram is at Dr. Mandelberger. No dots or anything. And my website for my practice is balanced with a D, medicalny.com. And then my educational component, All Things Menopause, website's under construction, will be highly improved soon, but it is still up right now. It's all-things-menopause.com.
And where do you see patients?
In Port Washington, New York, right on Main Street, quaint, not industrial medical building, right across from cafes and right by the train station, which goes straight to NYC.
And you also do telehealth.
And I do telehealth.
Yeah.
To New York only for now.
Got it. So yes, I see my therapy clients in New York, New Jersey, Connecticut, and Florida. I'm licensed in all four, but in person in Westchester County, New York. And I, like Dr. Mandelberger, love doing educational offerings, webinars for corporate, for schools, whatever it is, because education is key to breaking the stigma, to building community, to uplifting and empowering women. And you can find me on Instagram as The Counselor, but LAUR for Lauren. And millennial-menopause.com is where you will find my website and the book, which is available wherever books are sold. And it features expert advice from Dr. Mandelberger and almost 50 other experts in this space who are physicians, who are mental health specialists, lawyers, femtech founders, etc., because we need to be talking about these things. So thank you for talking with me today, and thank you so much to the Perry community.
Yes, thank you for having me, and I really enjoyed our discussion.
Bye, everyone. Reach out if we can support you.